Infant hip dislocations commonly occur in over 1 in 1,000 babies each year. Accessible screening, such as integrating automated methods, is critical to ensure patients requiring treatment are not missed. However, to ensure clinical adoption, it is important to replicate the current clinical steps for infant hip screening. This paper shows improved performance while replicating the clinical workflow by integrating the final clinical class into the loss function. Additionally, this work highlights the importance of considering all metrics in the clinical pipeline to determine the best method. Angle measurements in medical imaging tasks primarily rely on landmark localization. Developmental dysplasia of the hip, or DDH, is a disorder amongst infants where the hip does not form properly such that the femoral head is poorly located within the socket. The graph method is an ultrasound-based screening technique in which lines are drawn through anatomical landmarks to characterize the deformity. The most important feature of the graph method is an angle termed alpha, which is used to define severity and guide clinical treatment decisions. The clinical pipeline is replicated by our work as seen on the left-hand side of the poster. First, data was collected by Alderhay Hospital and the Royal National Orthopaedic Hospital. Second, landmarks were placed on the image. On the left, under the landmarks section, you can see both the manual annotations and the predicted maps from the model. Third, resulting landmarks are then used to calculate the graph angle, and the classification can be inferred by the determined angle. This classification is then used to diagnose and guide treatment for patients. We propose a method that accounts for non-Gaussian probability distributions, such as heat maps, to express model uncertainty to clinicians. The main contributions of this work were to improve current methods for automating the graph method by first including landmark probability distributions, or heat maps, and the graph classification into the loss function. Second, was to evaluate both the geometric outputs, landmarks and angles, as well as the clinical classification results. The methods are outlined in detail on the right-hand side of the poster. A UNet model was pre-trained on ImageNet using input ultrasound images. Each output channel corresponded to a single landmark as a Gaussian distribution. Unlike other work, the evaluation metrics were used to understand each step in the clinical pipeline. This includes landmark, angle, and classification metrics. Multiple loss functions were adapted to add the final classification to the loss. The baseline loss function was negative likelihood loss, using an image alone method. To aid the model in learning the effect of the landmark on the classification, we added a class loss to the loss function. Highlighted on the right-hand side of the poster in red is the mean squared error added to the loss function, and finally, a weighted class loss. This method found that the landmark method compared to those published in literature. Our angle measurements were within 2 degrees of the ground truth angles and agreed more frequently with resulting classifications than the image alone method. The accuracy of multiple raters against the ground truth was lower than the model accuracy. This work shows the improved classification performance by adding a weighted class to the loss function. It improves understanding of all metrics within the clinical pipeline, which can aid clinical adoption. Automated methods can help reduce healthcare costs by making diagnostics more accessible. I would like to thank my collaborators listed on this poster, and thank you for your time.